So today I'm going to be talking about a little history course on evolution of glioma surgery, talking about the past, the present, and a little bit about what the future looks like. So I'm going to start with a quote. This is by Oliver Holmes. He was one of her justices of the Supreme Court in the 30s. A page of history is worth a pound of logic. This is just to say, let's not ignore history. We can learn so much from history and not repeat the mistakes and make things better. So brief introduction, the history of glioma surgery parallels the origin of neurosurgery, and it goes over about 150 years or more in the modern era. For this talk, I divided the history of glioma surgery into 4 eras. The first one's a pre-modern era, the second one's early beginnings, the modern era, and then the new millennial era. And then I'll touch a little bit about the latest advances in the future that holds for glioma surgery. So in the pre-modern era, the brain was considered to be sacred, and cranial surgery, cranial interventions were rare. They were done for spiritual reasons in different cultures. When you look back to the records, the Egyptian period, the Greek period, the Byzantine period, and the Arabic period, you'll see that the early signs of burr holes or trepanations were back in 6000 BC. In fact, a lot of the historic figures such as Hippocrates, the father of medicine, he's written literature about neurological injuries and how to manage them. Similarly, Celsus, Herophilus, and Galen, they're key figures from the Byzantine time, and they've contributed significantly to the brain anatomy before we had imaging. That led to some of the initial surgeries before even discovery of X-ray and CT. Here I just want to show some historic pictures. These are skulls on the left side. These are 2 Incan skulls from 1500 years ago. You can see there's a really well-defined craniectomy per se done over here. The second image shows a skull from ancient Egypt, and third panel here actually zoomed into one of the lesions of the skull, and there's evidence of some metastatic process there. And all the way on the right, we're just showing some burr holes that were done back in ancient periods. Continuing on with the pre-modern era, in ancient India, there's literature about a surgeon named Jivaka who supposedly removed an intracranial mass. And Sushruta, he's a very famous master surgeon of India, actually the father of medicine in India. And apparently he contributed a lot to understanding of neurosurgery, particularly in the craniofacial anatomy. And reportedly, he had endoscopes that he would use for some of the facial surgeries he would do. But it wasn't until the 16th and 17th century when things started to pick up. And Leonardo da Vinci played a big role where he had these anatomic descriptions of the brain. He actually, had amazing drawings that I really couldn't find for the ventricles, intracranial ventricles, and brain anatomy. Carpi, as well, he had done significant work on head trauma. He actually published the first book that was dedicated to head trauma and management of head trauma. And he also, delved into brain anatomy as well and has contributions for the anatomy of the brain ventricles. Ambroise Paré was the father of modern surgery, and although he was a general surgeon, he had great input into head trauma as well. So there was a common theme of trauma in the pre-modern era that basically multiple surgeons and anatomists, delved into that to understand the brain. And then lastly, Vesalius, he worked in the mechanism of head trauma as well, but he really defined the parenchyma and dura, the different layers of protection over the brain. So the first ever documented neurosurgical procedure, or the cranial procedure, was done in 1561. This was done in Mexico City, and it was a 13-year-old boy who had sustained head trauma. And they did a surgery for elevation of a depressed skull fracture. In the same period, Thomas Willis, he was the first one to define the circle of Willis, or the cerebral circulation. This picture on the right is a reproduction of his original sketch that he had to define the circle of Willis. And then it was in 1865, for the first time ever, Rudolf Virchow, he used the term glioma. And this was to describe malignant tumors. And the word glioma is derived from glue, and he thought this tumor looked like very glue type. cells were like an extracellular matrix or glue that he called. So the early beginnings of cranial surgery or glioma surgery, I write here that craniotomy 101, because this is when they started developing a craniotomy for tumor resection. And the main goal here was surgical management of ICTs, which led to surgeries. So the first ever brain tumor surgery was done by William McKeven in 1879. It was a meningioma, and the patient survived 8 years. However, he died due to an unrelated illness. And the interesting part here is, there was no imaging back at that time, but there was the neurology field was blooming because the neurologists like Jackson and Ferrier, who did a good job of being able to localize lesions in the brain. And these were basically done based on two things: one, either head trauma, or two, based on focal seizures. And there's a whole literature about that we can discuss another time. So oftentimes, neurosurgeon at this time would talk to the neurologist, help with localization of the lesion, and based on their recommendation, they would plan a craniotomy. The first ever brain surgery for a primary brain tumor was done in 1884 by Godley. And it was a 25-year-old farmer. They've been following this patient for 3 years for left-sided seizures. He had a Jacksonian in March, and then he had a sudden decline over the course of a month. And basically, they localized the lesion just by doing a very thorough neurological exam. So the patient he had left-sided hemiparesis. We're looking at the eyes. He had right-sided papilledema or retinal hemorrhages as well. And they planned the craniotomy based on that. Unfortunately, the patient died within 4 weeks. Had a really bad wound infection, abscess, and brain herniation from edema. And after that, this Godley never performed another brain surgery. He continued to be a general surgeon. In the US, the first ever resection of a brain tumor was done in San Francisco by Morse and Hirschfelder. This was done 14 months after Godley did his surgery. It was in a 33-year-old male presenting with seizures, occipital headaches. They localized the region near the motor strip, did a 3-inch craniotomy. The patient improved after surgery, their weakness improved. Pathology at that time showed it was a glioma. Unfortunately, the patient passed away as well due to infection and intracranial abscess. So there was a challenge of septic technique, having limited antiseptic agents that they could use. Moving forward, the first ever textbook on surgery on the brain was published in 1893 by Starr. At that point, there were about 50 successful brain tumor removals, successful meaning the patient made it out of surgery alive. And then Balance, he wrote up a case series where he found there were more than 400 brain surgeries that have been reported. This was in 1907. And at that point, his idea was, or he understood that these gliomas are infiltrating neurons, and you really can't take the whole thing out. So, they thought that once you do partial resection, the tumor grows slower. So the idea of gross slower resection was just not present at that time. Furthermore, Heinrich Strobe was one of the first people who had a microscopic description of gliomas. And he confirmed that they are indeed infiltrative and stratified them into different histologic types. And he found one tumor particularly had more heterogeneity, which was now we know as a GBM. In 1895, Conrad, he discovered X-ray, and here on the right you can see there's an X-ray of the skull showing a calcified mass. So this was one of the latest advents at that point for imaging. So by 1899, there were greater than 600 operations for these intraaxial masses worldwide. However, there was a high mortality rate. In the cohort between 1884 and 1891, about 43% patients died after surgery. A decade later, it only improved slightly to 33%. So now, we have certain historical figures such as Victor Horsley, who really made a big difference in glioma surgery. Horsley was a general surgeon. He was a prolific he had a prolific surgical career. At the age of 29, he became a fellow of the Royal Society, and he was given a title job as a brain surgeon in England at that time. And by 1900, he had done about 44 glioma surgeries. Unfortunately, can't find his mortality rate. And he for tumors he couldn't resect, he would just do a craniectomy. And the whole idea was that we have to manage high ICPs. And we'll talk a little bit later, but when you do a craniectomy, they saw the survival rate was much higher when you don't do a craniectomy or do like a partial debulking of a glioma. Then came Harvey Cushing. We all know him as the father of modern neurosurgery in the US. He did extensive training, and in 1901, after a tour in Europe for a fellowship, he came back to Hopkins and was assigned as chief of neurosurgery, which was a new field that he was trying to establish at that point. In his first 5 years, his practice wasn't great. Only 29 brain tumors. There was a whole stigma about patients dying after brain surgery, so nobody really wanted to do that. However, he spent a lot of time perfecting his technique and also publishing good data, and eventually he developed a large referral base. And by 1910, he had operated on 200 gliomas, and his mortality dropped to 13%. So it was almost 40, it was 43%, but now it's 13%, which is amazing. And in the last 50 cases of his career, his mortality rate had dropped to 6%, which is just remarkable. And in one of his papers, he attributed this to better understanding of the intracranial pressure dynamics. So talking about ICP relief. And what he really did was he would just do a subtemporal decompression, which is unique to his practice. And a lot of people refuted that, even his disciples, but that worked for him. And the introduction of electrocautery, so having a bipolar really made a difference. And the field of anesthesia was blooming as well. So they were able to do longer surgeries instead of having to stage surgeries and take patients back. This table here showing the mortality rate. It was 17% in 1932, then it goes up and down through the decades, and then very low in 1994 to 2.7. You'll notice that there was no morbidity because they all expected deficits after surgery. So that was never a question at that point. Just briefly, the challenges of this era: there was difficulty accurately localizing tumor without imaging modalities. They would have a general idea of where the tumor is with the help of neurologists, but a lot of times they would have to expand their craniotomy to get to the tumor. Anesthesia, there were limited agents that could be used. It was difficult to have long surgeries. A lot of these craniotomies lasted an hour to 2 hours, and they were done. Antiseptics were also very limited that they were using. That's why the rate of infection was very high. And there was a lack of technical expertise in doing tumor resection. However, the goal here was to alleviate the symptoms of removing the tumor and reducing the ICPs. The modern era spans from 1919 to 1999. And in this era, a lot of pathologists focus on the histology of gliomas. So in 1912, Howard Tooth, he had published the first of a series and of 500 patients, and he was able to define what a glioma looks like. In his series, the overall survival was 10 months, and he basically was only able to describe whether a tumor was aggressive or not aggressive. But at the end of the day, that's not how these tumors work. But this was the first attempt to really classify them. In 1925, Globus and Strauss actually reported 16 patients, and this is when they coined the term glioblastoma based on its histologic characteristics compared to other gliomas. In 1926, Bailey and Cushing, they published the first classification scheme ever of tumors, and this was based on their presumptive cell of origin. And interestingly, you'll see since 1926, it was only in 2016 when the WHO had a new classification scheme. All right, I'll skip this. Other advancements in the modern era, we had the development of the ventriculography by Dandy, and then we had development of an angiogram by Igas Moniz in 1926. And these imaging techniques really help with localization of the tumor and also understanding, cerebral flow and the flow in the tumor. At this time, definitive surgical treatment of tumors, as opposed to just doing a decompression, became more and more common. And Dandy was one of the strong believers that we need to have, aggressive treatment of brain tumors. There needs to be radical resection. In fact, he's reported that he would try to remove the tumor, not just the tumor, also a rim of healthy tissue around the tumor, which, as we all know, is he's doing aggressive resection, which we do now. In 1935, the X-ray therapy was introduced, and some of these glioma patients, they were actually treated with X-ray. And there's mixed literature back in the 1930s and 1950s where it was either deemed to be beneficial or not beneficial. Moving forward, in 1949, this was the first time ever when there was an attempt to look at the extent of resection. And mind you, this is purely based on the surgeon's impression what the extent of resection is. And in a study by Davis in 1949, he basically found that the degree of resection, it correlated with the length of overall survival for a patient. And just to summarize this for the sake of time, this is a figure from his paper, and they don't have a Kaplan-Meier curve back then, but they basically showed there were about 11 patients who lived greater than 25 months, but less than 41 months. And these were the ones that they reportedly had gross total resection. In the 1950s, Netsky, he published a series of 83 glioma patients, and their average survival was 17 months, from the onset of symptom, but median survival from surgery was 8.3 months. And from this study, he claimed that as long as you have an aggressive resection, you're fine. You're gonna have, a longer median overall survival, but, there's no benefit from radiation, or it doesn't matter what grade of the tumor is. And this was, these patients did not undergo any radiation, or, I'm not sure about the pathology they didn't report in their paper. So it wasn't until Frankel and German, as well as Roth and Elvidge, these were two studies coming from Yale or from Montreal, where these were the first studies that basically supported the extent of resection having a good correlation with improved survival. Moreover, actually, the Montreal group also showed that these patients who underwent radiation, post-surgical radiation, had much better survival outcomes compared to the ones that did not. So I put these, figures here just give you, look at the one on the right. When you have X-ray after surgery, the survival is better. And they found there was significance there. But at the 2-year point, that's when, the difference didn't matter. Similarly, Hitchcock and Sato in England, they did the same thing where they basically concluded that if you have a radical resection and you have radiation, you have better outcomes as opposed to not. So looking at multimodal treatments, Boosie's group, they published a landmark paper in 1967, and they showed that there was significant improvement in the safety of extensive radical resection, and there was benefit of being aggressive in these patients. The one thing that they found was the single most important factor in improvement of in operative mortality was treatment with dexamethasone before and after surgery. And they found that if you start dexamethasone preoperatively, that was more significant than just giving it post-operatively. And you can see here in the figure here, in 1949, there's 48% mortality, and then it was 21, and then 2.9 in 1962 to 64. And it was 1962 is when they started using dexamethasone in Chicago. So at this point, neurosurgeons realize that surgery is just not enough for glial tumors, and there needs to be adjuvant chemotherapy. So there was a search for chemotherapy at this point. The first chemotherapy that they tried in a trial was 5-fluorouracil. However, unfortunately, it had no benefit in GBM. Mithromycin as well had no benefit. So there was a formation of the brain tumor study group, and this is a group that basically fostered clinical trials. And in 1978, there was a trial led by the NIH where they found that whole brain radiation after surgery was very beneficial. And this was, if it was given in addition to BCNU, patients did much, much better. There were 2 additional phase 3 trials, once again at the NIH and at MSK, which showed similar results. So based on all the work here, there was the standard of care at that point became, let's do radical resection and then give external beam radiation. But chemotherapy was still not very well established at this point, although there were trials suggesting that it's beneficial. Later on, there was 2 minutes. Yeah. There was also a search for other, chemotherapies, the implantable wafers here at Henry Bremen and Johns Hopkins, which showed there was slight improvement in survival. And in 2009, so 1998, temozolomide was used in a clinical trial, and it was found to be, have a good toxicity profile and a safety profile. So we used in phase 2 and phase 3 trials, and eventually stood over at Northwestern. They did a phase 3 trial where they found that if you get temozolomide after surgery and radiation, the median survival improved by almost 2.5 months, and it was FDA approved, and it's now a standard of care for glioma patients. So just in summary, there are 5 agents that have been approved by the FDA for gliomas: lomustine, BCNU, Gliadel, temozolomide, and bevacizumab. And just for the sake of time, I'm going to go a little quicker. So in the new millennium era, a lot of groups started revisiting the extent of resection. This is because MRI became very prevalent. We could really assess the morphology and characteristics of the tumor and actually the true, resection or extent of resection. There were other techniques that were being also used, awake mapping, motor mapping, which were usually used for seizure surgeries in the 80s. They were predating that, but now for glioma resections. The first ever paper published on looking at tumor volumetrics was here at MD Anderson with Raymond Sawaya, in which they basically found that if you do surgery, so there was a threshold for resection of glioblastomas, you have to resect at least 89% for significant survival benefit. And if you go all the way up to 98%, those patients greater than 98% had the greatest survival. Further, this was Berger's group at UCSF also did a study where they found, yes, there is a survival benefit with more aggressive resection, but the threshold for them was 79%. However, Vogelbaum's group at Cleveland Clinic at that time, they looked at residual, or they found that the contrast-enhancing residual tumor volume was more significant to predict survival as opposed to extent of resection, which they also found was significant. So just to show, during this time, awake craniotomies became more relevant and more advanced. We have other surgical adjuncts that are being used. You have 5-ALA being used for getting better resection. And what was really game-changing in the world of glioma was identifying molecular markers that were significant. So Dan Cahill at MGH and the group in collaboration with MD Anderson, they basically found that if there's IDH mutant contrast enhancing or IDH mutant glioblastomas, as long as you can do a good resection with the enhanced and non-enhanced region, there's significant survival benefit. MGMT also is an important molecular marker. This is a DNA repair enzyme, and if this is methylated, then you have better success with temozolomide or other alkylating agents. And just really going to touch on about the latest advancement in the future. These days, we're looking at immunotherapy, CAR T cells. We have dendritic cell vaccinations. There's introduction of intracavitary radiotherapy. You have radioiodinated monoclonal antibodies to extracellular matrix in the surgical bed. You have glia site radiation therapy. There's intraoperative radiotherapy.
Let's go to your last slide, Ankush, okay?
Yeah. Now a couple more slides. And then other techniques we're using is, we use lit, focused ultrasound, convection enhanced delivery of different agents. There's, the rise in oncolytic viruses again, and then targeted therapies based on tumor type. And then we have Optune. So I'm just going to skip the slide for the sake of time, but happy to answer any questions.
All right, thanks a lot.